Hi, this is Module 3. Today we're going to be talking about different study designs that can be used to study the epidemiology of physical activity. Specifically, we're going to talk about 4 types of study designs: observational, which is also called cross-sectional, case control, cohort, and randomized control trial. So once again, there are 4 different ways to study physical activity or diet and how they affect different health outcomes. First, we're going to talk about cohort studies, then case control, then cross-sectional, and lastly, randomized control trials. With cohort studies, essentially what you do is you follow a group of people, a cohort, over a period of time. Usually it's a long period of time, many years. So that's what we're going to talk about first. The first study, at least that I'm aware of, to study the relationship between physical activity and health was the London Transport Authority study, and you can see the article, part of the original article in the top right. It was published in 1953. What was done was that the author looked at individuals who worked for the London Transport Authority. He studied what he called conductors. These are people who are standing, walking, taking tickets, helping passengers, and so forth. And he compared their cardiovascular health to that of drivers who drove the buses and the trains. He did not study physical activity per se, but he used the occupation, either the driver or the conductor, kind of as a proxy for the amount of activity. So what he found, or what the authors found, is here in this table, and I'm going to try to slowly walk you through it. So in this column on the left you have age. This is important that it was broken up by age category because the outcome here was, if you look in the title, clinical episodes of coronary heart disease. So we know that age is a risk factor for heart disease. Okay? Then we have another column that they call man years observed. This is the number of time, or the amount of years that each individual was in the study. So if one individual worked for the London Transport for 20 years, he contributed 20 years of observation time. If a different individual worked there for 5 years, he only contributed 5 years. So it's a way to account for exposure time. And then you see rates here. Rates of angina, that's chest pain, so there was no angina in the 35 to 44-year-olds or the 45 to 54-year-olds. And then you see coronary thrombosis, that's a term that's not used anymore, but basically in this column, myocardial infarction is a heart attack. So you can see that the rates of heart attack were lowest in the younger group and they increased. And then immediate mortality in the first 3 days. This means that did the person die of the heart attack within 3 days. And then this here on the right is the total incidence. So really we're looking at these numbers here, 0.7 versus 2.5 versus 6.5. That's the total incidence of any bad heart-related event happening. Okay. Then all of this on the top is the drivers, and then the same information is on the bottom for the conductors. So the green is highlighting the rates of heart attack. And what you see if you look at the standardized rate, this is a mathematical formula that takes into account age. You don't need to know how to calculate it. But for the drivers, the standardized rate of heart attack was 1.5. For the conductors, it was 0.8. So the drivers were about twice as likely to have a heart attack. If you looked at immediate mortality, the rate was 0.9 for the drivers and 0.4 for the conductors. So the drivers, those who sit a lot, were about twice as likely to die of that heart attack. And then for the total incidence, for the drivers, it was 2.7. For the conductors, it was 1.9. So again, the drivers were more likely to have an incident of coronary heart disease or a related event. So the conclusion was, it seems like something related to the occupation, probably the sitting, but they couldn't say that definitively, is related to risk of heart. Here's another example of a cohort study, where again, you take a group of individuals and follow them over a long period of time. This study is called the Harvard Alumni Health Study. It's still ongoing. All of the subjects were males who were enrolled at Harvard University somewhere between 1916 and 1950. The study actually began in 1962, so they enrolled men who had been at Harvard during that time frame. They asked them about their physical activity currently. They asked about whether they participate in light sports, strenuous sports, stairs climbed, city blocks walked. Most of these individuals were businessmen living in the large cities in the Eastern Coast, so Washington, D.C., New York, Boston. So climbing flights of stairs in office buildings and walking city blocks was something they did frequently. Then they followed up the subjects in 1972, 88, and 93. They asked about, do you have a variety of diseases? If they could not get a hold of the person, then they looked for death certificates for those individuals. So they followed them over the period of time, looked at their physical activity, followed them up, and then of course tried to look for a relationship between those things, between physical activity that they reported and death. So the top number on the screen, lowercase n, means sample size. So in this study, there were 13,485 men. That's a very large sample size. And what you see on your x-axis here is they divided the groups into those who walked less than 5 kilometers a week, then those who walked between 5 and 10 kilometers, 10 and 20, and the most active group walked 20 kilometers or more per week. And then you see the mortality rate here on the y-axis, so higher up on the chart means a higher mortality rate. So what you see basically is that those who walked the least had the highest mortality rate, and those who walked the most had the lowest mortality rate. This is set up the exact same way. The only difference is the x-axis is the number of stories or floors climbed per week of stairs. Same thing, climbing more stairs was associated with a lower mortality rate. Similarly, moderate activity it looks very similar. There's a little bit of something interesting going on here at the end with the most active group having a little bit higher mortality rate, but in general, higher mortality rate was higher moderate activity associated with lower mortality rate. And then this is vigorous activity. More vigorous activity, lower mortality rate. So the Harvard Alumni Study clearly shows a relationship between physical activity and mortality rate. Here's another cohort study. This is a very famous one as well. It's called the Cooper Center Longitudinal Study, CCLS. It's also sometimes called the Aerobics Center Longitudinal Study, ACLS. This is a clinic that's based in Dallas, and what they do is individuals come in for a full clinical assessment, blood pressure, heart rate, cholesterol, etc. Hundreds of variables are measured. This includes a full graded exercise test where the individual exercises to exhaustion. It takes almost a full day to do all of the assessments, and they have over 100,000 individuals who have participated in at least one assessment. Many of these individuals go back several times, maybe not every year, but fairly frequently every few years, and so they have longitudinal data on those individuals. There's over 3,000 variables in the data set, but the catch is that the sample is mostly white men with a high socioeconomic status. This is because the assessments are not free. It costs several $1,000s to do this, but individuals who are very interested in their health status go for testing. So here is some of the data. So they're looking at the relationship between physical fitness, not just physical activity, but physical fitness and mortality, dying from any cause. So they had 7,080 women and 25,000 plus men. And these are broken up into low, moderate, and high fitness. So they just took the lowest third and called them low fitness, the middle third and called them moderate fitness, and the higher third called them high fitness. And then you're looking at death rates here on the y-axis. So for women, the low fit group had the highest mortality rate. By far, it was more than double, but there was no difference in moderate and high. And for the men, you see basically the same trend. The low fit group had a much higher risk of death than either of the other two groups. When they looked at just cardiovascular disease mortality, they saw something similar. Being low fit is very bad for your mortality risk, and that's been shown in other literature as well. Okay, so we've seen examples of 3 cohort studies where you follow a group of people over time and watch what happens to their health. The strengths of this type of study is that you can study many different disease outcomes. This is probably the greatest strength. You can study cancer and cardiovascular disease and muscular dystrophy and MS and any other disease that you could possibly think of. All of those develop over time, and so you can study anything that develops over time. Generally, you can determine what's called time order. This means cause and effect, essentially. Sometimes with some types of study designs, it's hard to know, did the cause come before the effect or not? But when you're looking over a long period of time, you can see that yes, the smoking did happen before the lung cancer or something like that. And because there's a large number of subjects, that allows you to often look at rare exposures. And exposure is something that's the cause or the proposed cause. So if you have 20,000 subjects, maybe only 500 of them were exposed to asbestos, but you still have 500 people who were exposed to something fairly rare. You can study those 500 separately and see if you can determine some of the health effects of that rare exposure. The weaknesses, obviously this takes a long time to do. If you follow people for 20 years, it takes 20 years to do the study. Because of the time-consuming nature of them, these are very expensive as well. And another problem is that methods can change over time. Say you are assessing someone's body composition, how much fat they have. Well, the way we assess that has changed several times in the past 20 years, or the best way to assess that has changed. And that can be a problem when you're trying to compare something over time. If the method is different, you're not sure if a change is due to if it's due to the method or something about the people you're studying. Okay, so we've talked about cohort studies. Now let's move on to case control studies. This is when you compare cases, somebody who has an outcome or a disease that you're interested in. So you compare cases to controls who don't have that disease. Alright, so I'm going to give you one example of a case control study. This is called the InterHeart study. You can see the graphic here on the screen, a global study of risk factors in acute myocardial infarction. Remember, a myocardial infarction is just a fancy term for heart attack. So basically what the aim of the study was to see if they could identify risk factors for heart attacks. So there were 52 countries studied, 15,152 cases. These were individuals who had had a heart attack, and those were compared to 14,820 controls who had not had a heart attack. And these were matched for age and sex. So what that means is that if you had a 40-year-old male who had a heart attack, they tried to find a control who was also 40 years old and male to compare to. The reason is we know that age and sex are both highly related to risk of heart attack. So the cases have all had a past heart attack, the control not. Alright, so here are the results. Let me try to explain this clearly. On the right hand side of the screen, you're looking at odds ratios here. So odds ratios, and odds of 1 means there's no additional or less risk, but an odds of 2 means you're twice as likely to have some outcome. An odds of 0.5 means you're half as likely. So if you see the dark square to the right of this dark line, that's an odds ratio greater than 1, and if you see the black square to the left, that's an odds ratio less than 1. So we're really primarily interested in exercise. Okay, so remember, we're comparing cases who have had a heart attack to controls who have not. So for females, 16.5% of the controls and versus 9.3% of the cases exercised. So if you look at the odds ratio, that means that people who exercise, women who exercise, are 52% less likely to have had a heart attack. You come up with a 52% by taking 1 minus the 0.48 that you see on the screen. For males, they are 23% less likely. So let me say that one more time. Females who exercise are 52% less likely to have had a heart attack, and males who exercise are 23% less likely to have a heart attack than males who don't exercise. Just to look at diet a little bit, you can see a similar trend. Eating a high number of fruits and vegetables greatly reduce the odds of heart attack for both males and females. So here's one more example of a case control study. The question that was being addressed was, is persistent pulmonary hypertension in infants related to drugs that a mother takes during pregnancy? Really what was going on is that there was this thought that antidepressants, a specific category of antidepressants called SSRIs, thought that maybe they were causing pulmonary problems in babies. And so what was done was a case control study. So what they did is they called mothers of babies who were born at a variety of specific hospitals. Some had persistent pulmonary hypertension and some did not. And 68% of the control moms agreed to participate, and 69% of the PPH moms agreed to participate. That's important because if there was a vast difference in those numbers, that could be a bias. And then they matched them by what hospital they were born in and the date of birth. Okay, so here is the description of the data. So this is, in the yellow, moms who used antidepressants never, anytime, or who specifically only took an SSRI. That's the kind that they were really interested in. And they looked at babies, 377 babies who had PPHN, matched to 836 controls. And so the reference group, or the one we're comparing to, is moms who never took antidepressants during their pregnancy. What you see is that the odds ratios are a little bit higher for women who take antidepressants. But if you look over at p-values, without going into a lot of statistics, if you want your p-value to be very small, to be less than 0.05. Make sure you write that down. That's really important, and we'll see it again. If a p-value is small, that means that odds ratio is statistically different from 1. So, for instance, the p-value the odds ratio for taking an antidepressant anytime during pregnancy is 1.3, but the p-value isn't small. So that means that really 1.3 isn't any higher than 1, statistically speaking. So this suggests, this data highlighted in yellow, suggests that antidepressants are not a problem as far as PPHN goes. But then they looked at this a little bit differently with the timeline. They thought, well, maybe the timing of taking the antidepressants matters. So again, the reference is women who never took any. Those who took antidepressants before 20 weeks of pregnancy, so in the first half of the pregnancy, they actually had a lower odds ratio, so they had a reduced risk of PPHN in their baby. But if you look at the p-value, that's not significantly different. But here's the very interesting part. Those who took antidepressants after 20 weeks had a 2.9 times greater risk of their baby having PPHN, and that, according to the p-value, which is very, very small, that is significant. And then if you look just at SSRIs, you see something similar. You see that after 20 weeks, taking an SSRI after 20 weeks increased the risk of PPHN by 5 times. So it was concluded from this case control study that SSRIs after 20 weeks do increase the risk of this outcome in babies. And there in red is the critical information. So case control studies, again, you compare cases, someone who has a condition. So we looked at myocardial infarctions as an example, and we looked at babies with PPHN as the other example. And that's comparing to a control who doesn't have that condition. So the strengths are that these are pretty quick and inexpensive in the grand scheme of things. You don't have to follow anyone over time. You also need fewer subjects, and you can study rare outcomes. For instance, PPHN, persistent pulmonary hypertension of newborns, is very rare, but you can find everyone in the country, for instance, who had PPHN and study all of them. Whereas with a cohort study, you have to follow people over time and wait to see who develops that rare outcome. Weaknesses are a problem with time order. It can be hard to determine if the cause or the proposed cause really came before the effect. Problems with recall bias. For instance, the mothers of the PPHN babies, something bad happened to their baby, so they may recall things differently or be more hyper alert to certain exposures than women whose babies were fine. And also, case control studies are typically not useful for rare exposures. Alright, so far we've talked about cohort studies and case control studies. Next, let's move on to cross-sectional studies. Sometimes these are also called observational studies. I believe that's what your textbook uses. This is when you study the relationship between an exposure and an outcome only at one point in time. So this is an example of a cross-sectional study. They wanted to assess the relationship between a mother's physical activity during her pregnancy and what is called the fetal growth ratio. So a fetal growth ratio is birth weight divided by the predicted birth weight for that gestational age. So that means if a baby, say a baby's born at 40 weeks, that's kind of the average full-term baby. If the baby weighs 8 pounds and the predicted birth weight for a 40-week baby is 8 pounds, 8 divided by 8 would be 1. So a fetal growth ratio above 1 means the baby was bigger than expected. A fetal growth ratio below 1 means the baby was smaller than expected. They used accelerometry to measure physical activity. We talked about accelerometers yesterday. These are pretty sophisticated devices, and then they divided into 4 groups: the least active, the next group, the next most active, and then the highest active 4th sample. There were 51 participants. And so here's what they found. The least active quartile of women, the birth weight of the babies was 4,000 grams. And then they got a little bit smaller as the women became more and more active. And then you see this is basically the similar data. On the x-axis is physical activity. It's in METs. Don't worry about what that means. Just know that further to the right means more physical activity. And then the fetal growth ratio, remember 1 is the baby was exactly the size it was expected to be. Above 1 was a little bit bigger than expected. Below 1 is smaller than expected. So what this is showing is that women who were more active had smaller babies. This is an example. Again, I'm showing you this because it's an example of a cross-sectional study. You're just looking at the relationship between the size of the baby and the physical activity at one point in time only. These are quick and inexpensive, and that's really the only strength. Weaknesses are that you cannot determine time order. We don't know that the physical activity caused the baby to be smaller. It could be that the baby being small caused the woman to be physically active. We cannot say that one caused the other. That's a huge weakness. Therefore, you can't use this design to study outcomes that develop over time. For instance, mortality. You can't study mortality in a cross-sectional manner, and you can make no assumptions about the cause of any variables or any outcomes. That's very important. Here's just an example of that concept. We cannot say that just because two variables are related to each other, that one causes another. So if this is a cross-sectional study example, a silly example, but when I was in graduate school, we used to I taught an anatomy lab with multiple sections, and we would measure, or we would count the number of students wearing Chacos, everyone's favorite shoe, right? And their average exam scores. So the section where more students were wearing Chacos performed better on the exam, and the section where few students were wearing Chacos performed more poorly on the exam. Does that mean that wearing Chacos makes you smarter? Well, no, of course not. This is an example of how two variables are related, Chacos and exam scores, in a cross-sectional way, but that does not mean that one causes the other. So similarly, we can't conclude that physical activity during pregnancy causes babies to be born smaller. We don't know what causes it, we just know that those two things are related. All right, the fourth type of study that we're going to talk about is a randomized control trial. These are often abbreviated RCT. These are true experiments where you do some kind of manipulation of the exposure. You do something to the participants. There's also randomization and a control or a placebo group. So this would be, you have your study participants, you randomize them to either get an intervention or to get no intervention. The easiest way to think about this is a drug trial, where you are randomly either given a drug or you get a fake drug, a placebo, to assess the effectiveness of a new drug that's being tested. Okay, and then you measure the. So these are designed to minimize bias. The techniques that are used are randomization. So say you are you have 100 people with cancer and you want to test out a new drug, you randomly assign that 100 to either get the real drug or get the placebo, the fake drug. The randomization is done to increase the likelihood that all other variables, maybe their height and their weight, or their fruit and vegetable consumption. If you randomly assign the 100 people to the two groups, then there's an increased likelihood that half the people who eat lots of fruits and vegetables are in one group and the other half are in the other group. You don't have to try to account for all of that. Blinding, you can single or double blind. You can single blind, that's when the participant doesn't know what group they're in. They don't know if they're getting the real drug or the placebo. And it's even better to double blind because the participants and the researcher don't know which group. This is sometimes a problem. Maybe if it was an exercise randomized control trial, if the researcher knows which group the participant is in, he or she might encourage more or do something that would help the participant perform better. Usually it's not intentional, but researchers can definitely bias studies, so double blinding is preferable. There's also a concept called intent to treat, and this says that everybody who starts the trial, everyone who's randomized in, must be included in the analysis. So if someone drops out, they still have to be included. So this is very important then to minimize people dropping out. If a drug, say it's a drug study and this drug causes a lot of side effects, that can be a big problem. And so this must be kept in mind. Also, if you're doing a physical activity intervention and it's very time consuming, say they have to come to your lab 5 times a week for an hour, well, people are probably going to drop out of that. One thing you can do to try to minimize this, crossover is when somehow the control or the placebo group gets some of the treatment. So maybe if it's an exercise study, 2 friends are in the study, one's in the treatment group and one's in the control group. Well, if the one in the treatment group is learning all of these really cool workouts and is excited about it, he might share that what he's learning with the friend who's in the control group. And in that case, that's a problem because the control group is actually getting some of it. Here is an example of a randomized control trial. And the research question here was, does the timing of consuming ibuprofen affect the response, the bone mineral density response to resistance exercise? So this is really interesting in terms of osteoporosis. We know, you probably are aware that resistance training or weightlifting helps build bone mass. But we wanted to know if taking ibuprofen before or after exercise can help build more bone mass. And so here's what you see. What everybody did, these were all women, and they were in one of 3 groups. The white bars here represent taking ibuprofen before their resistance training exercises, and then they took a placebo pill after. The gray bars are, it's mismarked, but the gray bar is both placebo. They never took any real ibuprofen. And then the black bars are a placebo before and an ibuprofen after exercise. And so any of the bars above going upward indicate an increase in bone density. That's a good thing. Any bars going down indicate a decrease in bone density. And what you see is that all of these different locations, these are locations for measurement of bone density. So at the lumbar spine, total hip, femoral neck, trochanter, and femoral shaft, the group that took placebo before and ibuprofen after had the greatest increases by far in bone mineral density. So this suggests that taking ibuprofen after resistance training actually somehow causes the resistance training to work better in terms of increasing bone mineral density. So this wasn't a randomized control trial because the participants were randomly assigned. There was blinding. They didn't know which group they were in. They just took the pill when they were told. And the treatment was the ibuprofen or the placebo. The non-treatment was the true both placebos. But this is a little bit different from a traditional randomized control trial because all of the participants, whether or not they were getting the true treatment, they all had to do the resistance training. So there was kind of almost a second treatment, but everybody did it. So they had to do the resistance training, and then they either took the placebo or the ibuprofen. So the pros and cons are: the pros minimize bias, the randomization, blinding. This is the best design to show causation. If you want to show that a variable X causes a variable Y, you almost always have to do a randomized control trial. The cons: it can be ethically challenging. The randomization, especially in drug trials, it can be challenging. If someone is terminally ill and they are assigned to the placebo group, they have no hope of getting better, and they don't know if they're in the placebo group or not because of the blinding. So that can be difficult. There's arguments that it's unethical not to do the randomized control trial because you don't determine if these treatments work or not, but you can see how there's some ethical concerns there. And then if there is vastly different dropout in the treatment versus the control groups, that can be a really difficult thing to overcome. I also want to mention community trials. Sometimes randomizing individual people isn't possible. For example, if you wanted to see the effects of physical education in a school or fluoride in a water supply, you can't give one individual fluoridated water and another individual not. So what they do is they randomize communities. So you might give one school physical education and one school would be the control group, or you might give one community fluoride in their water and a neighboring community would not get the fluoride. So really this is similar to a randomized control trial, but it's just the level of intervention is different. The problems with this are when people move, if they move from a community, say, that doesn't get fluoride to one that does, or vice versa, or they move away entirely and they're lost to follow-up. And especially with physical activity, it can be really hard to measure the physical activity level of a whole community. So that can be a challenge. Your assignment for today is to do the first Epi in the News, and the instructions are posted on Moodle.